Dr. Valastro, welcome, welcome. Where are you riding
Mhm.
the storm out, Dr. Valastro?
I'm in my home, which so
Okay.
far is good and safe.
Fantastic, fantastic. All right. Well, listen, everybody, put the questions in the chat box. I think Dr. Valastro and I will get rolling. If we get both my colleagues joining in, I'll have them added in. Real quick, shameless plug here. Make sure you like or follow us for more information regarding back pain, shoulder pain, elbow pain, cervical pain, those types of things. If you aren't yet, please make sure you give us a like or follow on any of the socials to gather more information, or go to the website and check out one of our awesome blogs. And if you want to just call and schedule after this webinar, please, we'll put this up again at the end. So, Dr. Vlash, would you like to kind of take it away and start with the anatomy and what causes back pain? I think that would be a good place.
Sure. So when we're looking at the spine, it's a very complicated structure, multiple different components that can contribute to pain. So you've got the vertebral bodies stacked on top of each other. Most people think of that as their back, the bones in the spine. But between each of those bones, there's a soft tissue disc, which acts as a cushion and helps with range of motion in the spine. That disc itself can be painful. There are also nerves that pass behind those discs and out through the holes in the spine. Those nerve roots can be painful for narrowing of those holes or because the disc is bulging out onto them. There are joints in the back called facet joints, and those are just like a knee joint, shoulder joint. They have cartilage. They can become inflamed, arthritic, irritated, so they can cause pain. And then also you have soft tissue structures, ligaments, muscles that help stabilize the spine, and those can all work together to contribute to pain. So the ligaments, there are many more than you would expect in the back. There are ligaments between each level in the back and also on the sides. Then once you get down into the pelvis, you have a more complicated structure of ligaments there connecting the sacrum and the pelvis. And all of these things can become imbalanced and contribute to pain. These are some of the muscles that I was referring to. Core muscles we think about in the front as our abdomen, and that contributes to core, but the core also wraps around to the back. So all of the muscles in the back help with the stability of the spine. So when we've got atrophy or imbalance in some of these muscles, it can lead to pain in the muscle itself or asymmetry in the spine, which can cause pain to the spinal structures. This is an example of something that can cause back pain. So we've got an MRI on the left of a spine, looking at it from the side. You've got that soft tissue disc, which the red arrow is pointing at. It's bulging out into the back, into the spinal canal, likely pushing on some nerve roots in that spine. So that disc itself may be painful from the bulge in the abnormality of the disc, but then also the nerves can be painful because they're getting some pressure on them from that bulge. Different ways to treat spinal pain. In your standard pain management practice, you will be offered things like physical therapy, which is great. That helps with the alignment, stability of the core and the spine. Steroid injections for inflammation, radiofrequency ablations or burning the nerves, some people call it, spinal stimulators, surgery, and sometimes narcotic medications. And there are reasons to try to avoid some of these things. Sometimes there are situations when back surgery is necessary, and we would definitely point you toward that if that was the case. And these are situations where you're losing function in your body. So if you're getting progressive weakness in your legs or sometimes your arms, if it's your cervical spine, or if you're losing control of your bowel and bladder, and that can indicate pinching of some important nerve roots down in the lower spine. And you would want to take care of that pretty quickly with a surgery. Epidural steroid injections, these are some of the more common things that are used for back pain. They do have some pros, which are that they can quickly reduce the inflammation in an area, which can reduce pinching of some of the nerve roots, which then reduces the pain that you're feeling from that inflammation. But it is a short-term solution. It doesn't really heal the structure. Cons to steroid injections are that they're toxic to cartilage and soft tissue in the area. They can lead to osteoporosis, so weakening of the bone density. They are also immunosuppressive, making you more likely to develop an infection. And because they are toxic to cartilage, they can accelerate osteoarthritis. radiofrequency ablation. So this is where a doctor will put some probes on sensory nerves that supply the sensation to some of the structures in the back, usually the facet joints in the back, and they burn those nerves so that you no longer feel pain coming from those joints. This can give 6 months or so of pain relief if it is done properly, but these nerves, they do regenerate. So it's not something that lasts forever, which is why that pain relief is not permanent. And then also, the nerve that is sensory to the facet joints, it also does innervate a small muscle called the multifidus in the low back. And when we reduce the innervation of that muscle, then we reduce the stability of the spine, which then leads to accelerated wear and tear of those joints because they're not as supported by the muscles. Some alternatives to these treatment options that we offer with regenerative medicine include PRP, platelet-rich plasma, and bone marrow concentrate. These things are developed with the healing components that you naturally have inside your body. In your bloodstream, you have platelets to repair injury. So when you have a cut in your skin, they form a clot, pull the tissue back together, and they send out signals to stimulate cell turnover and tissue repair. So we create platelet-rich plasma by drawing patient's blood, concentrating those platelets, and delivering them in areas that we need help with healing. Bone marrow concentrate is also something that we can use depending on the situation. So that has same growth factors, healing components as PRP, platelet-rich plasma, but it also has mesenchymal stem cells, which are a bit more potent in healing large tears or significant arthritis. So sometimes that can be the best choice depending on the situation in the spine. So as I was saying before, these regenerative medicine injectates, they are stimulating the healing process that the body already has within it, just giving it the ammunition to initiate a repair process that it hasn't been able to do on its own. You know, you might have a herniated or torn disc, and the body can try to heal it, and sometimes it does, and sometimes you feel better after a few months, but oftentimes it doesn't heal. So we need to regenerate or re-stimulate, I should say, the healing process in the body to get your disc more healed and reduce the pain and improve your function. As I was talking about earlier, the spine has many different structures that contribute to pain, and a lot of the time, multiple structures are contributing at the same time. So we like to treat discs by addressing all of those structures. The discs, the nerves, the facet joints, the ligaments, the muscles, we target all of those things and make them healthier and stronger so that the spine is more stable as a whole to get the better or the most optimal pain relief possible. Next slide. Here are some X-ray images of injections that we have done with fluoro. So you can see, first picture, there is contrast inside a disc space. Second one, we have contrast flowing where a nerve root comes out. That's a transforaminal epidural. We've got facet joint injection, got SI joint injection, got interspinous and supraspinous ligaments. We've also got iliolumbar ligaments. So these are all things that we are specifically targeting during a spine procedure, and we use contrast X-ray, we use ultrasound to be very sure that we are targeting those specific structures. Next. All right. So we have a few studies.
Do you want me to talk about this?
Yeah, sure. You go ahead.
So we have a study that was done by the Regenix affiliate in Oregon about lower back pain, half with radiating symptoms. And I love this study because we have a couple pictures associated with it. And it really shows us the active population when we do a full spine approach for our lumbar spine procedure, i.e. the discs, the nerves, the joints, the ligaments, the muscles. And what we saw was we were able to see some of these disc herniations, extrusions resolve and get better. And that was associated with Another picture here where we have the disc herniation, and then I would probably call that an extrusion, and that resolved with our procedure. And then this is more of a degenerative disc where we see less inflammation. So we can help with more of an acute issue, whether it's a disc herniation or extrusion, or the degenerative type disc disease, and get very, very promising results. And this was really the VAST visual acuity score for pain for these patients. And we saw that, we went from an 8 out of 10 pain to a 0, a 6 out of 10 to a 0, a 10 out of 10 to a 0, a 6. This person looks like appears to be lost to follow-up, which means that they didn't come back. And you know what? We could probably just count that as a failure. But for 13 patients here, very, very promising and good results: 7 to 0, 4 to 1, 8 to 5, 4 to 0, 9 to 0, 9 to 0, 7 to 3. And so this is what we saw with this study. And we got this data because we track all of our outcomes. And that's something that makes Regenix much, much different than every orthopedic group out there, where we are really, really dedicated to making sure that our patients get back to doing what they love. So this is another study that was done by Kirchner and Tua in 2016. It showed 90.7% showed a excellent response at the 6-month mark. And typically that's what we're waiting for. Really, we see pretty good results at 1 month. We have some improvement, is what I tell my patients. At 1 month, typically we see at the 12-week mark, we see even better improvement, but usually about the 6-month mark is where I would tell somebody that they've experienced maximal improvement. I say between the 3 to 6 month mark is where we get somebody to plateau and really reach where they're going to be. And this is a multi-factor injection, just like the things that we do, where you're hitting the facets, the transforaminal, PRGF, and those types of injections. This study was done by Mary Ambach et al. She's actually somebody I've actually taught with at the orthosono course in Las Vegas. And this was low back pain greater than 12 weeks. Ages was between 18 years old to 80 years old. Somebody couldn't have an active infection, neoplasm, any of the really bad exclusion criteria. And it was a multi-targeted PRP approach. And this is very similar to our approach. And that's why we talk about it here. And what the results were was that about 85+% were very satisfied to satisfied with their outcome of these injections. And over 85% again said that yes, probably yes, and definitely yes, they would do it again. So there was also 6.5% of people who didn't respond. So we don't really know what to say about that, but it was a pretty good study, and we really love this approach in getting our patients get better. So here's the registry data that I alluded to earlier. And this is what we see in our follow-ups is about 1 month out, a 61% improvement, and really about the 6 months, 64% improvement. So I usually tell my patients I get about a 50 to 60% improvement, aim on the low side. Sometimes I hit home runs, sometimes that's right about the average. We rarely strike out. We get very, very good results with patients, but there are some patients who are non-responders, and that's tough to figure out, tough to determine based on, we have to see you in office to determine whether you'd be a good candidate or not. What we can and cannot do is we do see disc morphology improvement. Typically, we see less pain, more function. We're able to get patients off narcotics and NSAIDs, but we don't typically see is disc height changes. Somebody wants me to pump up their disc. I haven't been able to, there's been nobody that I know of. And Dr. Valastro, have you heard of anybody able to rebuild discs at this point?
No, not yet.
Not yet. We're hoping that it gets there and things progress in that direction. And that's why we're very, very encouraged. And that's why we're trying to help stave off any type of surgery, because we feel that there's really isn't, any great surgery to increase your disc height at this point, and 100% efficacy for everyone. That's just if somebody tells you that 100% of the time works every time, please walk the other way. They're not telling you the truth, because there's no 100% in medicine. The disc changes here, we can see some improvement. And then what we'll do now is, here's another one. There's a patient of Dr. Leiber's that really had a favorable result. This was after a second injection, and you can see in these images here, I was annotating earlier, probably should I do that again, that you can see this here and this here, and then what ended up happening is you can see how much improvement there was in that space right there. So really, really good, promising, good results with our approaches. And then I think we're going to take questions here. Again, if you haven't liked or followed us, here's our social media info, and we'd like to take some questions at this point. You got a Q&A. So, Dr. Valastro, I will pose the first question to you. I'm not seeing it come up. Is it popping up for you? Hold on a second. Do you mind?
It's the Q&A the chat doesn't have questions in it, but the Q&A does.
Okay, I'm clicking on Q&A. Do you want to read the first question off?
Yes, someone's asking how to get the recorded video and previous webinar videos.
So all those videos, typically we'll upload the videos to YouTube within the next 48 to 72 hours, with our staff being under hurricane warnings and watches. That might take until next week, but we will try to get it up here within the next 48 to 72 hours.
Next question was about the studies in the PowerPoint and if they were for PRP or for stem cell. I'm pretty sure that all of the studies we discussed in this presentation were for PRP or platelet-derived products. So sometimes it's concentrated platelets and sometimes it's platelets that have been frozen and filtered, but all of those are derived from a blood draw where we're concentrating the patient's own platelets.
Yes, that is the Regenix approach, and there is a study that shows that very, very favorable results for severe degenerative changes with by Dr. Murphy et al. I'll pull up that. Let me actually. You're still looking at what screen are you looking at right now? This one. Okay. I get if somebody's interested in that study, please let me know. Shoot me an email at ron.t@newregenortho or actually at regentampabay.com, or just contact me on one of these socials and I can get back to you with that study. But most of our studies were most of the research points to PRP as being the first option, and then if things get really, really bad, there are indications to inject into discs, and there's 6 and 1/2 dozen the other that say PRP into the disc versus bone marrow into the disc, and we can talk about that at the consultation. And otherwise, really, really good indications for PRP. So you got a next question? I don't know why I can't pull this up. It's not pulling up for me.
Next question is, I've plateaued at 6 months. Will I decline from here and need follow-up injections? I'm at a 1 to 2 in pain right now. I'll answer this. So we are taking data from patients that have had these procedures done through Regenix, and from the graph that we showed in the PowerPoint, we're able to track patients out about 7 years at this point. And for the most part, it seems like the relief that patients are getting is sustained. There are some situations with more significant wear and tear of some of the joints in the low back that pain might start to creep back a little earlier than that 7-year mark, and repeat or follow-up injections, even just partial injections, maybe not doing the whole approach, might be a good idea. But for the most part, we do these injections and we hope that the relief we get is sustained for many years to come.
And you're looking at my home screen now, right? Aren't you? Is that what you're looking at?
Yep.
All right, I can get the question answers, but I can't. So that's okay. I don't think anything on there is that bad. All right, so just so I can get some questions in here, and then I'll go back to the shared screen. I don't know, how do I get it back to that screen actually? There we go, got it. Okay, great. So how can I get it recorded? We answered live. The chat is disabled. All right, you can ask in the question and answers. Are these studies for PRP? We answered that, correct? Answer live. Great answer there, Dr. Valastro. I'm just gonna catch up, sir. How long does research show it lasts? Great question. I'll let Dr. Valastro answer that. How long does research show it lasts? And then I'll chime in if I have any other commentary.
Yeah, so similar to the last question, what we're seeing with patients that have been treated by this full spine approach is that for the most part, it is sustained for as long as we've been following them, which is for about 6 to 7 years. For certain abnormalities, like maybe a herniated disc, if we can get that disc to shrink back, I mean, the goal and the hope is that that disc stays that way. There are some situations that you have a progressive wear and tear, like the joints in the low back, and they might need some touch-up injections down the road. But that would be something that we wait and see how things go, and we don't necessarily plan or expect to have to do them.
Great answer. I couldn't say it better myself. So I've researched that sometimes these types of injections can cause bone spurs, which can be painful. What is your experience in this area? Please show me the research, because I've not seen that. It actually shows that it actually helps decrease inflammation, and the rubbing and associated with the rubbing from the facet joints that happens causes some of the that causes the I've not seen bone spurs, but if you can show me that research article, I'll be happy to take a look at it. If I have difficulty standing for more than 10 minutes at a time, is this something that can be helped? Dr. Valastro, would you like to comment on that?
Yeah, it's hard to tell what the difficulty standing is associated with. Is it leg weakness? Is there some numbness going into the legs? If it's coming from the spine itself, there's a good chance that we can help with it. If it's from stenosis of nerves or something like that. If it's something beyond that, maybe a peripheral neuropathy, that's hard for us to treat, or a myopathy, that might be something different. But if it's originating from the spine, there's a good chance we can help with it.
Right. I have a broken L5 for the past 20 plus years. My issue that I deal with is arthritis. Is this a procedure that could have good results for me? I'll answer that, Dr. Valastro. Really depends on what we see on X-ray, MRI, and in clinical exam, where we think that this pain is coming from. And that's what the consultation's for. So I'd like to give you an answer right here on this, but unfortunately, a good consultation will really tease out a lot of what is going on. If it's the arthritis in the facet joints, yes, we've seen the ability to get these this much better. If this is more something else that isn't facetogenic, we can go from there and take it from there. Dr. Valastro, you want to take this? We mentioned 6 months for noticeable healing. What are the do's and don'ts during downtime, and for how long? Uh, i.e., they want to snowboard in January to March 2025.
Yeah, so it's not 6 months of downtime. That is something we should make clear. So immediately after the procedure, when the healing response is starting, you will feel a little bit worse than normal, a little bit sore and stiff, but that's usually the first 2 to 5 days. And then you feel about your baseline level of pain. So you'll start increasing your activity about a week out. We like you to be working with physical therapy starting about a week after the procedure to start rebuilding your core strength, your extremity strength, improving your muscle patterns. So it's something where you're going to be back to your activities sooner than 6 months, but you're going to be continuing to feel improvement from the procedure up until that 6-month mark, sometimes a little bit beyond that. It's usually by 12 weeks that people are back to the activities they were hoping to be back to.
Great answer. After treatment, after procedure with PRP, piriformis fatigue returning after 6 months, suggestions. I'm going to give you the suggestion. Are you working with PT, physical therapy? How often, how frequently, what kind of exercises are you doing? Those are some suggestions that I would have off the cuff. If I'm not your treating physician, talk to them what their suggestions would be, but that would be what I would recommend. Dr. Valastro, would you say anything differently?
No.
I'll ask you this, Dr. Valastro. Do you believe your cervical procedure can fix instability? The question is, let's say fix, okay? I think fix is kind of the questionable term here. I think we can help with it, but I'll let Dr. Valastro. She's really the upper cervical and cervical specialist, in my opinion. C2, C3, C4.
Instability due to the soft tissue, we can definitely help with. Part of it is injecting the stabilizing ligaments and the muscles to help activate them and make them more, just improve the stability there. If there's a bony instability, that might be something where surgery should be involved. But we can do a lot with the injections that we do and also the proper physical therapy to help strengthen the muscles in the neck, and improve the alignment there.
Great answer. External rotation seems to quiet fatigue, or what else can I do? External rotation, again, if the fatigue is coming on with external rotation, that's usually your external rotators, which would be some of your piriformis muscles and some of those muscles in the the buttock area. So again, I would really look into making sure that you're getting appropriate exercise and appropriate strengthening of those muscles, because fatigue usually comes on with exercise, or fatigue usually comes on due to lack of deconditioning, and in my opinion. But again, Dr. Valastro, would you say anything different? Like, I mean, it could be a nerve-related issue, but you should probably always follow up with your doctor, who's your treating physician. But Dr. Valastro, anything different on
Yeah, no, I think you covered it.
that? Hey, Dr. Torrance, I'm doing very well. I wanted to thank you. Thank you very much. Always a pleasure. Always are super grateful. Always have patients responding and getting better. That's our mission and goal. So thank you so much for jumping on. Um, Another question here. Do you believe in a chiropractic before neck injection? Uh, you might have to. Do you believe in what atlanto-occipital chiropractic? Is that the question? Do you think, Dr. Valastro? I'm trying to
That's how
interpret
I'm
it.
reading it. Yeah,
Okay.
that's how I'm reading it.
Uh,
Um, is it necessary before the injection? No. I think that a lot of chiropractic adjustments can be temporarily helpful by shifting some things in the neck and the symptoms that are associated with that. But our injections are meant to cause more long-term change by helping with stability and alignment, by stimulating repair and improvement of the bulk in the stabilizing ligaments and muscles. So I don't think necessarily that a chiropractic treatment before is going to make it a better or worse outcome. But we do want to be careful with chiropractic treatments immediately after, as the spine is starting to recover and stabilize and heal from the injection. So immediately after, we would say to hold off on those for a few weeks.
Great answer. Can C2 to T1 treat it at once? Actually, that's what we prefer to do. We prefer to treat the whole spinal unit. There's actually a really good paper by Chris Williams et al. About that and about the case study, really treating from C2 down to T1. So yes, we prefer to do that to really help the stabilization of the whole cervical spinal unit. So, Dr. Vlash, I'm going to answer this one. Can you explain why platelets concentrated can generate healing that lasts? Aren't they aged just like your stem cells? I'm going to ask you the same question. If you get a cut, does your body heal itself or does it keep bleeding out? So your platelets work just like any other platelets. Your stem cells will continue to work as they age. Typically, after the age of 80, is a decline in your stem cell concentration in the body, but our body cells continue to work as we age, and concentrated platelets will continue to work and do very, very well. There's multiple studies that show it. Would you say anything else, Dr. Valastro?
Oh, very good.
I like that analogy. Nobody's going to bleed
Yeah.
out. Will your research help in the future to get Medicare and other insurance companies to cover eugenics costs? Josephine, this is a fantastic question. Our group's the only one in the world that actually has self-funded insurance coverage. So that means that not the major medicals like Blue Cross, United, it's the companies that actually care about their employees enough to actually have us as a benefit. So there's 2,400 self-funded companies that cover us, and that's how we've actually gotten that research. That's one of the reasons why we did the research, was to show that this is better than orthopedic surgery. And we have groups like 7-Eleven, Marine Max, the Diocese of St. Pete, Manatee County Schools, City of Port St. Lucie. There's a lot of different people who consider us a very valuable benefit to their team. So thank you for asking that question. Does the piriformis muscle receive its fatigue from the joint? Dr. Valastro, you want to answer that?
It's really hard to say why a piriformis muscle might be fatigued. It can be because it's working harder against an arthritic joint. It can be because the innervation is not robust if there's a pinched nerve somewhere. It can be because of the way that you're moving and chronic muscle imbalance. It's really hard to say without an examination.
Great question. And then we'll get a follow-up on and we can discuss further. Don't want to throw anybody else out there. Dr. Valastro, can you inject into thoracic, specifically T11 and T12?
Yep. So the thoracic spine is structured very similarly to the lumbar spine. So we can do transforaminal epidurals, we can do joint injections, we can do ligament muscle injections, just like the other parts of the spine. There are also extra joints from the ribs, because ribs are in the thoracic region and not in any other region. And they can contribute to pain, and we can also address those. So yes, long story short, we can treat thoracic.
Great answer. With bone marrow injections, do you grow the stem cells prior to injecting them back into the patient? I'll answer that. In the United States, and the way we do it in the United States, it's minimal manipulation, and we do not culture or do anything additional to your body's cells from the bone marrow. They are concentrated and separated, and then they are re-injected back. Now, that's what we can do in the United States. I do go to the Cayman Islands where we do cultured cells, where we do culture the stem cells out of your bone marrow aspirate. And those procedures are different, and they are not in the United States because of the way the FDA views culturing of cells as creating a drug, and that's why we don't do them here in the States. But we do get a good number of cells from a quality bone marrow aspiration, which is something that every patient should ask. How many bone marrow aspirations has that clinician done? I tell patients that I do 2 to 4 a week, and that's the truth. I did 4 this past week. And if somebody hasn't done enough, they aren't doing a quality aspiration. And that's really something that you should ask. When was the last time somebody did one? All right. When can I use an inversion table after injections and TENS machine? I think that's really kind of varies per doctor. I say usually about 2 weeks afterwards. What do you usually say, Dr. Valastro?
For inversion table, I would say about 2 weeks. For TENS machine, I think they can use that, right away to help with pain relief. I don't think it's going to cause any negative effect.
Another question, please discuss your own stem cells versus those from umbilical cord. Can the latter be done in the United States? So using your body's own cells, you put old in parentheses, they're your cells with lack of rejection capabilities, which I think is one of the biggest things here. There have been no known umbilical products here in the United States that actually culture out live stem cells. We have a blog about it if you want to jump on the website, neurogenortho.com, to take a look and read about that. It comes from a paper that actually looked at that. And so there's multiple studies that show that, and there are no actually FDA cleared umbilical stem cell products at this point. So there's a couple questions there. There's a lot of unpacking to do. Really, if somebody's injecting umbilical cords stuff here in the United States, they really don't know what they don't know, in my opinion. But Dr. Vlash, what would you say to that?
Yeah, I think that the outcomes are always better when you're using cells that come from your own body, because your body recognizes them and is able to work with them much better than something coming from another body like an umbilical cord cell.
Okay. And then when you have multiple areas of pain and you are 79, can one very large injection help many areas? Well, Diane, let's have you come in for a consultation and let's talk about what we can do to help. Let's see where the issues are coming from. There could be just one spot that really is the main root cause of this, but it sounds like there's a lot of stuff going on and we need to unpack a lot there. So Dr. Vlasto, would you say anything different?
Yeah, so oftentimes people have multiple body parts that they like to treat. Sometimes we can treat multiple at one time, but we want to be careful about how much blood or blood product we take from someone, whether that's blood or bone marrow. We might have to split multiple body parts over a couple of different treatments just so that we're not taking too much from your body at one time. Also, it's a lot for your body to focus on repairing multiple different structures at the same time. So there are some situations we can couple together, but other situations we want to spread them out.
All right. Well, that's the end of the questions. Thank you everyone for tuning in. Again, Sarasota, Tampa, St. Pete, and Orlando. Please stay safe in this hurricane. The storm surge looks pretty nasty. Dr. Velasco, please stay safe. Thank you so much for your time. And we should be able to get this up on YouTube here in the next 48 to 72 hours. And thank you again.
Bye, everyone.